Now, giving comfort measures. This is something that we need to realize that we can do. Do you want to make sure that you speak in a calm voice? Make sure that it's clear. You want to help keep the parents calm because they affect that child. You want to explain anything and everything you do regardless of the patient's neurological status. If that patient is even unconscious, you need to be explaining this. Get yourself into the habit of doing this all the time, every time, with all of your patients. Okay? Determine if the patient can tolerate medicinal pain relief. You may want to, think about, giving pain medication sometimes can drop the blood pressure. Is your patient already compromised? Does he have delayed cap refill? Is already tachycardic, working hard to breathe? You may and may not be able to use medicinal pain control. So you need to be familiar with things that you can do, just talking to a patient calmly in a clear, concise voice. Small children, just, singing to them or just comforting them with your voice. Using older children can actually, use visual techniques, find a spot and focus. If you're having to do frequent neurological checks, you may not be able to utilize those pain medications because they can interfere with these. So there's a lot of things that you need to consider before giving medicinal pain control and comfort measures. Now let's talk a little bit about your history. I like to use this little acronym, MIVTP. You want to look at the mechanism of injury. This can tell you a lot about your patient. If you understand what happened and how they moved in this accident, then you can actually find several hidden injuries. You'll be prepared and know where to look. You want to identify all of your patient injuries, life-threatening first. You want to get your vital signs, and that includes all of those that we talked about before. Any prior treatment, if you are not the first person to take care of this patient, then you need to know what was done to this patient before they got to you, okay? If you were not the first responder, then you have to get previous treatment. And then past medical history. You want to get that from your family, your bystanders. If you have bystanders and they can tell you what happened, you can talk through the mechanism of injury. That is very useful information, and it needs to be passed on from one caregiver to the other so that nothing gets missed. You want to begin your head-to-toe assessment. You want to make sure that you look at each section of that patient's body, starting with the head and scalp and face, okay? Not just around the head. You want to make sure that you palpate that face. If they have multi-system trauma, you've got to do a complete head-to-toe. You always want to make sure that you listen before you palpate, okay? If you go mash on the belly, then you may not get to listen because you have now hurt them. So you want to go through the head and face, the neck. You want to make sure that somebody holds manual C-spine on these patients and that you actually feel the back side of that neck, remove that C-collar, okay? Your chest, you want to make sure that you palpate all the way down the chest, feeling for any crepitus, any abnormalities that you see. You want to make sure that you feel the sternum. Abdomen, the same thing. Like I said, you always want to listen. You want to look first, then listen, and then palpate. If the patient is complaining of pain in a specific quadrant, you want to do that quadrant last, okay? You want to assess the pelvis. We do not do a pelvic rock anymore. If there's a pelvic fracture, that's very dangerous. You want to kind of just ease down on the pelvis and make sure that it's stable. If not, you will want to stabilize this with some type of assisted device, a sheet. They make bands for that. And then you want to do each and every extremity. And like I said, if the patient has an injury, an obvious injury to a specific point, do that part last. You know, if you're going to do all the extremities and you know you've got a fracture of the left arm, do that arm last, okay? Because you won't get a good assessment of your other extremities. Next thing we want to talk about is log rolling. You have to look at the back side of your patient. Your patient has two sides, okay, a front and a back, and you have to look at all of them. When you look and you roll, you want to palpate all the way down that spine and the posterior ribs to make sure that there's no injuries, bruising, contusions, all of that. And then once you get the patient log rolled, you want to inspect that perineum as well, because you can have hidden injuries there. You want to look at urine output. If the patient's had some urine output, that's a good sign of circulatory status, okay? Well, that was kind of fast. We went through the primary and secondary survey, and now we want to talk about proper immobilization. For smaller children, you want to make sure that you pad, like I said, from the shoulders all the way down the torso to the buttocks, okay, to get that whole thoracic cavity up and keep it in line. You don't want to just use a shoulder roll because that takes them out of C-spine where it's all straight, okay? You want to make sure that you keep them in a neutral position by padding all the way underneath them. That keeps the occiput from pushing forward on the head and occluding the airway and taking that cervical spine out of alignment. You want to make sure that you can actually C-spine immobilize a patient on a long adult spine board, but it's going to require a lot of padding. You're going to have to pad around the patient. You don't want any lateral movement of this patient when you move this board. You need to make sure that if you have to tilt this patient due to emesis or anything else like that, that when you do that, this patient doesn't slide from one side to the other. Secure the head last, okay? If you secure that head first and you have to roll them before you get the rest of this patient secured, if they didn't have a cervical spine injury, they could now have one because their head's tied to this board and their body is going to move from one side to the other. So always the head is the last thing to be secured and the first thing to be released, okay? So these are the references that I used, was the Trauma Nurse Core Curriculum course from the ENA and Pediatric Education for Pre-Hospital Professionals, also known as PEP.